All right. I gave you a little longer. So we're going to get back to it. We're going to move into some female reproductive anatomy and some female physiology and a little bit of female pathology. So the reproductive role of the female is more complex because we do deal with pregnancy. When we're dealing with our anatomical structures, though, we have our ovaries, which are our female gonads. They're going to produce our female gametes or ova. They also secrete our female sex hormones like estrogen, estradiol, estrone, and estriol, as well as progesterone. We have our internal genitalia and our external genitalia, and so we'll kind of get into some of the structures here. If you're a visual person, this is your picture to kind of orient you again. Rectum, bladder here, pubic bone here, uterus here, etc. And we'll go through some of these structures more in detail. But when we start with the ovaries are paired structures. They flank our uterus. They're about almond shaped, and they're about twice as large. I don't know about that. They're typically about almond shaped or pea shaped when you feel them. They get smaller over time, obviously postmenopausal. They have several different ligaments, and I mentioned before that the NCLEX loves to test you on ligaments of everything. So the ovarian ligament anchors over the ovary medially to the uterus. So the ovarian ligament is going to link medial to the uterus. Our suspensory ligament of the ovary, we talked about one with the breast, is going to anchor the ovary laterally to the pelvic wall, and the mesovarium is going to suspend the ovary. The suspensory ligament and the mesovarium are both part of the broad ligament that supports not only the ovary, but the uterine tubes, uterus, and vagina. So if we look here, I don't know if this is a good picture. It kind of shows a few of them. We'll have a better picture in a few slides. But we can see the suspensory ligament of the ovary is here. I think that's the only one we see in this picture. Oh, we have a round ligament over here. We will get a better picture here. Suspensory and mesovarium are part of our broad ligament. The ovarian ligament is not part of the broad ligament. So of these three, the ovarian ligament that anchors medially to the uterus is not a part of our broad ligament. The suspensory and the mesovarium are. I have never seen an NCLEX that has not had a question on these ligaments. Yeah, it's just, they love them. I hate them and they love them. Yeah, know them, love them, then you'll never probably use them again. It's just what it is. Especially NCLEX 1, absolutely. I think what I use the most is micro and biochemistry and immuno. I use those three areas the most in my day-to-day clinical practice. Physiology, sure, but like it's mainly surface level. It's not as in-depth. Anatomy, very rarely do I need to know an origin or insertion of the muscle. I don't think I've ever needed to know that clinically. Action, sure, but yeah. Anyways, that's my aside. That's when I start writing my passive aggressive notes on the exam. Like, why is this important? I wish they would find those someday. I'm sure they'd be funny. Okay, so blood supply for our ovaries. We have our ovarian arteries, which are branches again of our abdominal aorta. So both of our gonads, male and female, our vasculature comes from our abdominal aorta. Those vessels are going to travel through our suspensory ligament and our mesovaria. So they're going to travel through the broad ligament. That's another way of saying that, right? Because our suspensory ligament and our mesovarium ligament are both part of the broad ligament. So this is a non-clear way of saying that the vessels travel through the broad ligament. I hear that question asked as well. Every ovary is surrounded by a fibrous tunica albuginea, which we've seen before in our male testes, which is great. It's covered then by this germinal cuboidal epithelial outer layer. The germinal layer is continuation of the peritoneum. So you could think about the peritoneum becomes this germinal layer, and then there's a fibrous tunica albuginea that covers our ovary. And so here's the picture that's much better. So we see our ovaries are located here, and then we can see our broad ligament is this kind of structure here. You're going to see your mesosalpinx, mesovarium, mesometrium. Those are all just different layers of broad ligament. You see then our ovarian ligament directly connecting that ovary to the uterus. And we're other structures which we haven't discussed yet. We've just been over here so far. Oh, and then our suspensory ligament over here. It's very much a sheath. It contains the vasculature. It contains the, like I said, the mesovarium, and it contains your ovarian ligament, but it is itself this whole kind of broad sheath that attaches the ovary to kind of all these structures within the pelvic wall, pelvic body. Yes. Yes. So the tunica albuginea of the ovary, you could almost think about that as the fibrous capsule, where that was the tunica. So tunica albuginea is the fibrous capsule. You could think about that the same way as the testes, but instead of having two layers, the ovaries have this germinal layer that is pretty much the peritoneum. So they just have the peritoneum, which becomes the germinal layer once it comes onto contact of the ovary. And then within that is the tunica albuginea. So slightly different. You could say, one could say the ovary is maybe more exposed. The reason for that, it does have to release an egg, which the egg just gets released into the pelvic region. It typically will get caught by our fallopian tubes or our uterine tubes here, but it can get released, and that's how you can have an ectopic pregnancy. It doesn't actually get all the way into your uterus because the egg this is open space. It's not directly enclosed. So the ovary does have this outer cortex that houses our gametes, and this inner medulla that contains our vasculature and our nerves. So within the ovary, you have a cortex that has your gametes, your follicles, and your inner medulla that contains the nutrients needed. Ovarian follicles themselves are these sac-like structures that are embedded in that cortex layer. They contain an immature egg, which is called an oocyte, and they're encased by one or more layers of a variety of different cells, which we'll look at. And each month, a ripened follicle, ideally, if you have normal menstruation, each ripened follicle will eject an oocyte, and that's ovulation. Like I mentioned, the uterine tube system does not have direct contact with ovaries. So an ovulated oocyte is released into just the peritoneal cavity, and some oocytes are never make it into the system. Most of the time when that happens, if there's no sperm around, they're not fertilized, they just get degraded by the body's immune cells. But if there was sperm, they did get fertilized, and they got fertilized outside of that ductal system. That's how you can implant an ectopic pregnancy in that peritoneal space. But our tube system contains the uterus tube, or uterine tubes, or fallopian tubes. They will use both terms, the uterus and the vagina. So uterine tubes, I've also seen oviducts, actually, so I've seen all three of these here. They will receive your ovulated oocyte. They're typically where fertilization occurs. And regions of the uterine tube, contain the infundibulum, the ampulla, and the isthmus. So the infundibulum is this kind of funneled shape opening to the peritoneal cavity. And it has these fimbriae, and you can think about them as like trying to grab their finger-like projections, trying to grab the egg, pull it in, right? They don't actually grab it, but they're kind of trying to capture it. The ampulla is really the majority of it's about half the uterine tube length, and it's where fertilization occurs. That's where you should associate your ampulla with. And your isthmus is your medial third that just empties into the uterus. So think of the infundibulum has fimbriae that are going to catch the oocyte. Ampulla is where, if fertilization occurs, that's where it would occur. And isthmus is where it's drained or funneled into the uterus. So during ovulation, that's when you're going to capture that oocyte, carried via peristalsis down and ciliary action. So it does have peristaltic contractions and cilia that move those eggs down. If there's a non-ciliated cell present, their purpose is to provide some type of nourishment. So they're metabolically active in providing nutrients that are necessary for the egg and sperm, the fertilized gamete. Or oocyte and sperm, they're not gamete yet. And there is they are covered by peritoneum, just like everything really in this space. And there is a structure called the mesosalpinx that supports the tubes. And so we'll look at what that looks like here. It's part of your broad ligament. So again, when in doubt, everything's a part of your broad ligament. So you have your mesosalpinx, which is part of the mesoovarium. So mesosalpinx is kind of this fibrous structure up here that supports your uterine tubes, versus your mesoovarium is this fibrous structure here that's supporting your ovaries. And your mesometrium is like this fibrous structure down here that's supporting the base of the ovaries and the endometrial tissue. Again, also a part of your broad ligament, your ovarian ligament. So everything, and the vasculature, everything. But then we can see our fimbriae here, our infundibulum here, our ampulla here, and then our isthmus there. So those are important structures to recognize. We don't need to actually be able to identify them on an anatomical sense. Yes? It's gonna continue the sheath down until about here. The uterosacral ligament here, that would be where it stops. So the uterosacral ligament comes through here, and then this space below, that's no longer broad ligament. Broad ligament is going to be this whole space. Yeah, it kind of reminds me of like what an ileum looks like, right? It's not seated in the ileum, but it kind of almost looks like that. Like it's supporting all these structures of the endometrial structures, the uterine tubes, and the ovaries. So it helps keep them in place and kind of provides some protection. Everything would just be kind of floating every which way in that space, right? In that cavity space. So we talked a little bit about ectopic pregnancy, but PID, pelvic inflammatory disease, is a spread of infection, or it can just be an inflammation of the reproductive tract that can spread upward to the peritoneal cavity. The big piece that you need to think about with PID is it does not have to be infectious, so it could be due to a just inflammatory state. Which means it could be caused from trauma, it could be caused from retained products of conception, and it can lead to scar tissue and infertility. Those are the big complications that most of the time they'll ask you about. So our uterus then, moving into other anatomy, is a hollow, thick-walled muscular organ. Its whole purpose is to receive, retain, and nourish a fertilized ovum. And it can be anteverted or retroverted. This more matters when we start doing pelvic exams, but essentially anteverted is going to be inclined forward, which is normal. Retroverted is going to be inclined backward, which is abnormal. But again, all are normal in the sense that you can see many of them, and they aren't associated with pathology. The uterus has several regions: the body, the fundus, isthmus, cervix, and cervical canal. The body is the major portion. Fundus is this rounded superior portion. Isthmus is this narrowed inferior region. Cervix is the narrowed neck or outlet that projects into the vagina. And then the cervical canal communicates with the vagina via the external os, and the uterine body via the internal os. And then you have cervical glands that secrete mucus that blocks sperm entry, except during mid-cycle. So an aside on cervical cancer, it's relatively common. If you thought of what testicular cancer is to males, you could think of cervical cancer being to females, although cervical cancer is more common than probably than testicular cancer. But it's a little bit younger age that we'd see. So some risks can be cervical inflammation, certain STIs, specifically HPV. Being null parous or moldy parous actually can be a risk factor. So they say multiple pregnancies, but also null pregnancy can be a risk. And pap smears are your detection. So what are some supports of the uterus? We talked about the mesometrium. This is a part of the broad ligament again. So I mentioned mesometrium supporting the endometrium is part of the broad ligament. When in doubt, broad ligament's probably a good yes. Then there's three others: the cardinal, the uterosacral, and the round ligament. Oh my gosh, they never end. So the cardinal ligament or the lateral cervical ligament comes from your cervix to your superior vagina to the pelvic lateral walls. And we'll look at these on this next picture. Your uterosacral ligaments secure the uterus to the sacrum. That makes sense. And your round ligaments bind your uterus to the anterior wall. So if we look here, we can see we're talking now about the uterus. We see our round ligament of the uterus is going to come out anteriorly, binding us to the anterior wall. So that's our round ligament over here. I'm going to change my color. We have our uterosacral ligament coming over here, binding us to the sacrum, so moving posteriorly. These are not portions of the broad ligament that I'm highlighting. Then we have the cardinal ligament or the lateral cervical ligament, which is this down here. This structure here is our lateral cervical ligament. Again, now not a portion of our broad ligament. Our broad ligament is up here, containing the mesosalpinx, the mesovarium, and the mesometrium. As you can see, we also have several other structures that run through the broad ligament. Our suspensory ligament, which is not actually suspensory ligament, it's not part of the broad ligament. Don't listen to me there. That's its own thing. Suspensory ligament, its own little structure. I'll give it its own color. There, suspensory ligament, its own color. But other structures that run through the broad ligament are ovarian ligaments here. Our vasculature, we can see vasculature moving through here and ovarian blood vessels moving through here, so vasculature. And you even see the ureter exiting through the broad ligament. This is just another view. So I would suggest you kind of look at both pictures. So again, prolapse of uterus. So when the uterus sinks inferiorly, the tip of the cervix can actually protrude through the external vaginal opening. A big piece with this one is even though it's anchored by many ligaments, this isn't an issue with our ligaments failing. This is an issue with the muscles of the pelvic floor failing. So that could be a really good pathology question, is asking what structure can lead to prolapse of the uterus, and they might give you some ligaments, and you're looking for a muscle. You're looking for any muscle of the pelvic floor. Oftentimes they'll give you broad ligament, round ligaments, and sacral ligaments, and then they'll give you a muscle. And it is the muscle that's the answer that they're looking for. Unless if it's like bicep, don't choose that. But they'll give you a muscle of the pelvic floor. The uterine wall itself has 3 layers, a peri, a myo, and an endometrium. So the perimetrium is the outer layer. You can think of it as the peritoneum, right? The cover. Myometrium is the middle layer that has smooth muscle that contracts during childbirth or during your cycle. And the endometrium is a mucosal lining. This is made up of simple columnar epithelium. The fertilized egg will burrow into this layer and reside there during development. It's very metabolically active tissue, right? Columnar cells have room for a lot of stuff, a lot of organelles, a lot of things that they can support. So the endometrium does have 2 layers, 2 strata. The stratum functionalis and stratum basalis, or the basal layer, the functional or basal layer. Functional layer is going to change in response to ovarian hormone cycles, and it's going to be the thing that sheds during menstruation. The basal layer is going to form the new functionalis layer, the new functional layer after menstruation, and it does not respond to hormone changes. That's why it's able to create a new layer every month regardless. So once the layer sheds, the basal layer says, oh, it's my time to build another one. The layer sheds then. It says, oh, it's time to build another one. And that process continues. Think of the basal layer as almost like the stem cell layer of the endometrium. The uterine wall itself has lots of vascularity, which makes sense if it's able to support a fertilized egg. It has to have a big blood supply role. So you have uterine, arcuate, and radial arteries. The uterine arteries are going to come from your iliac arteries and branch into the arcuate and the radial arteries. Arcuate arteries are in your myometrium, the muscles. Your radial arteries are in the endometrium and go into straight and spiral arteries. Straight in the stratum basalis, spiral in the functionalis. So what does that look like? I think this is easier to view. So you have your uterine artery. It's going to branch into the arcuate artery, which is going to branch into the radial artery. Okay, and so we've moved now into our first layer of our endometrium. These are then going to branch into straight arteries or spiral arteries in the actual internal endometrial tissue. So this branching pattern, if you wanted to learn one vascular component of the reproductive system, this would be a good one to commit to memory. But if that's not your jam, don't do it, right? This is time where it's high yield only. So if this is stuff that is hard for you to commit to your brain, don't commit it to your brain. Yes. Correct. They're going to repeatedly degenerate and regenerate. So every cycle, they're going to go away when they get shed off during menstruation, typically. And then they're going to regenerate from straight arteries. Straight artery will actually come from the radial artery. But straight arteries provide nutrients and support to the basal layer. Therefore, they're not shed off every month. The spiral artery here does not become another straight artery. This is just would be branching of the spiral artery up here through the superficial tissue. It looks like the straight artery, but it does not come another straight artery. Nope, straight artery only in that basal layer. It's just in the basal layer. The spiral artery is going to become this spiral structure, and it will branch like capillaries, but it still is the spiral artery. Yeah, absolutely. The vagina, I think the most important piece of the vagina to keep in mind is that there is smooth muscle there, muscularis. And then there is also this rugae, right? The external tissues kind of has these like rugae, these bumps, these regions, and that's covered with stratified squamous mucosa. I think those are the big pieces of the puzzle because it's going to secrete mucosal secretions. So there's lots of things to know about the vagina, but I would say important pieces are it has smooth muscle and it has stratified squamous mucosa with rugae. Adult vaginal secretions are typically acidic but alkaline in adolescence. They become less acidic when a semen enters into the vaginal canal, which decreases our body's ability to want to destroy semen and think of it as not self. That's why semen can actually make vaginal environment more alkaline and can lead to infection down the road. Because acidic secretions help prevent infection and things like recurrent BV or yeast infections, etc. Okay, I'm moving through some of these things. I want to make sure that we get to the goods. So I'm going to move past external genitalia for now. We talked a little bit about this already. We talked about suspensory ligaments attaching breast to underlying tissue. We will talk a little bit about mammary glands, and we'll get into functional gamete production for the female. So mammary glands, they're lobules within lobes. They contain glandular alveoli that produce milk. Milk is passed into our lactiferous ducts, and that go to lactiferous sinuses that open outside the nipple. In a non-nursing woman, non-lactation, glandular structure is underdeveloped, but breast size itself is related to fat, not related to this glandular tissue or structure. And if you're a visual person, again, this is what we were talking about. You have our suspensory ligaments here, which I mentioned. So there are suspensory ligaments in the breast tissue. Then you have your lobule containing alveoli. You have your lactiferous duct moving into a sinus, moving out the nipple. That's where breast milk goes. So you have your alveoli, lobule containing alveoli, your duct, your sinus, moving out through the nipple. Breast cancer, most common malignancy and second most common cause of cancer death in US women. Very common. You may have a question about it on your test. Null paris women or first pregnancy late in life are risk factors. Early onset menstruation or late menopause are risk factors. No or short periods of breastfeeding or family history. But a lot of women will have breast cancer with no known risk factors. This is a really good genetics question asking about BRCA1 or BRCA2. So if you see BRCA1 and BRCA2 and there's something talking about breast cancer or genetic risk of what type of cancer, lean into breast cancer as being an option. It also can lead to ovarian cancer as well. And pancreatic, yep. Absolutely. We don't need to talk about diagnosis. Okay, good. This is what I wanted to get to. Oogenesis. So this is our production of our female gamete, not our female game, female gamete. Versus spermatogenesis was our production of a male gamete. So you are going to start this process in the fetal period. So this is different than males. You start with oogonia, which are diploid stem cells. These are going to divide via mitosis to produce primary oocytes, to undergo meiosis 1 to produce secondary oocytes, to go under meiosis 2 to produce ova. So a similar structure, but starting at a different timeline. So what are the differences? They love asking this. 3 key differences between oogenesis and spermatogenesis. Production of primary oocytes only occurs in the fetus. Whereas in spermatogenesis, you can have your primary initial sperm produced throughout life once puberty hits, right? So it's different. That's why there's a discrete amount of time that women can conceive. In primary oocytes, meiosis is arrested at late prophase 1 and resumes only years later, if at all. So there is this like arrest phase. It'll start meiosis 1 and it'll start late, and it'll go through late prophase 1 and then it stops. And then in secondary oocytes, meiosis is arrested in metaphase 2 and is only completed if fertilization occurs. So there's some of these stopping points, these points of control in the female reproductive system for oogenesis. So the things involved here, what are the players? So we have I want to talk a little bit about our oocytes and follicles. So we have our ovarian follicles. We've mentioned them already. The ovarian follicle is that functional unit of your ovary that includes one oocyte. It's surrounded by 2 cell types, pregranulosa cells, if a single layer of cells is present, or granulosa cells, if multiple layers are present. So it's pre if it's just 1 layer, and it's granulosa if it's multiple layers. The primordial follicle, kind of your like beginning primordial ooze, that's what I think about, is your single layer squamous pregranulosa cells surrounding your primary oocyte, the most kind of basic structure. So if we look at follicle development here, we see our pregranulosa cell and our oocyte. This is a primordial follicle here. So our primordial follicle is then going to move throughout life until menopause. They'll begin to grow and develop. They'll become eventually a primary follicle. Then if stimulated, they might become a secondary follicle. But primordial, primary, and secondary follicles all contain primary oocytes that are arrested in prophase 1. So all of these follicles contain the same type of primary oocyte that's stopped in prophase 1. So again, we can see our mitotic events. We have our oogonium, our stem cell, undergoes mitosis to become a primary oocyte. Meiosis starts but stops, so we keep having a primary oocyte and primary oocyte. We'll talk about what can trigger that continuation in a minute. So then looking at what these follicles are, so once we have had our primordial follicle, a primary follicle has now a single layer of cuboidal pregranulosal cells. Secondary follicles then have multiple layers of granulosa cells. They're all still surrounding a primary oocyte arrested in metaphase 1 or prophase 1. And our tertiary or vesicular or antral, any one of those names, follicles, have this fluid-filled cavity around called an antrum. And typically before ovulation, a primary oocyte inside the tertiary vesicular antral follicle will resume its meiosis and become a secondary oocyte. So what does that full structure look like? So once the secondary follicle becomes a vesicular antral follicle, then we'll see meiosis 1 will complete just before ovulation. Meiosis 2 will then start, but stop in metaphase 2 unless if fertilization occurs. So again, we have our secondary oocyte arrested in metaphase 2. We'll have our first polar body. We'll talk about this in a minute. If sperm is present and sperm and secondary oocyte meet, then meiosis 2 is completed. But that's only if sperm penetrates the oocyte. So again, this process starts in the fetal period to get our primary oocytes, but it takes years to complete. Our primordial follicles develop in the fetus. Our primary oocytes are arrested in prophase 1. Our follicles will have 2 different fates, all of our follicles, either atresia or ovulation. Atresia is apoptosis, so programmed cell death. Almost all of your follicles are never recruited. Almost all of them go through atresia. Then you have ovulation. Each month after puberty, a few primary oocytes are activated. They get selected to the team. This is going to be caused by high hormonal levels, specifically FSH. Remember, FSH was involved in both. And when this group is selected each month, one of them from this select group, the A team, gets to become their MVP, their dominant follicle. The dominant follicle, like I mentioned, starts meiosis 1 right before ovulation. After the meiosis 1 is completed, you have 2 haploid cells of different size, a first polar body and a secondary oocyte. The secondary oocyte is the one that would continue to go down this oogenesis pathway. The first polar body is a small cell that doesn't have really any cytoplasm, so it's not functional. The secondary oocyte is a large cell that has all the cytoplasm. It stole all the cytoplasm from both cells you could think of, and has all the organelles that it needs. Your secondary oocyte then stops in metaphase 2. And that cell is what will become your ovulated ovum. If not penetrated by your sperm, the oocyte deteriorates. If penetrated by sperm, it will quickly complete meiosis 2, giving us an ovum and a second polar body. The ovum, again, large cell, tons of cytoplasm, enough to nourish a fertilized egg for about 6 to 7 days as it journeys down to the uterus to implant. And then the secondary polar body is, again, tiny cell, no cytoplasm, it's going to die off. A lot of waste in oogenesis, right? There's a lot of stuff that ends up dying off or apoptosing or not being functional. So if you're visual, again, this is that same picture. So if we compare it again, oogenesis to spermatogenesis. Spermatogenesis produces 4 viable sperm. Oogenesis produces 1 viable haploid ovum with 2 to 3 haploid polar bodies. Occurrence during life, spermatogenesis begins in puberty and it goes to old age, versus oogenesis begins in fetal life and ends in menopause. And the error rate for spermatogenesis is lower. Oogenesis has an error rate that's higher, mainly because oogenesis only gets 1 per time versus spermatogenesis has a lot more chances, right? They're producing a lot more sperm than we have functional ovum. And you can see the total time to produce 1 gamete, 74 days for males, 13 to 50 years for females, right? Depending on when you have that ovulation. And 50 years is average, right? Some people end menopause at 40. Some people go on until their late 50s or even 60s sometimes. Occurrence during lifetime is different. Number of gametes is different. Number of gametes then per life is different. The error rate's different. And the cells surrounding, you typically have 1 cystinocyte, 1 Sertoli cell that can sustain many spermatocytes. And you'll have many granulosa cells sustain 1 oocyte. It's different, right? Multiple cells sustain 1 oocyte in female reproduction, oogenesis. 1 Sertoli or cystinocyte gives lots of nutrients to many different spermatocytes. We've talked a little bit about the follicle development stages, but I want to talk a little bit about ranges of control or hormones and how that stimulates certain factors. So our maturation of follicles can occur in 2 phases. So phase 1 is where it's the pre-antral phase, and it's gonadotropin independent. So it involves intrafollicular paracrines, which, remember, paracrines are things that are secreted locally and act only on local cells. So this is phase 1 is localized control over growth and development of that initial follicle. In phase 2, you have an antral phase, which is stimulated by FSH and LH. So that's when we get the hypothalamus and the pituitary gland to actually come into play. So that FSH and LH stimulation, that's what helps us decide to select a dominant follicle, so a follicle that has probably the best chance And that's when your primary oocyte is going to resume meiosis 1 and complete that process. So until then, when it's only localized control, that's not enough to push a oocyte or follicle through, well, oocyte through meiosis 1. So our primordial follicle will become a primary follicle. That process can take almost a year. Trying to think if any of this is super duper important. I think knowing just this functional process, knowing that we got to get to that vesicular follicle to then be able to move down into our secondary stage of meiosis 2. In the process of moving from a primary follicle to a secondary follicle, big component that would be important here is we have this connective tissue component, and granulosa cells will actually condense and they form what's called the theca folliculi. Thecal cells then from that region secrete hormones in response to LH. So that's the biggest important piece here is in primary moving into secondary follicles. That's when we see fecal cells come into play and they secrete hormones when LH is present. And LH, remember, is our big stimulation luteinizing hormone that allows us to have ovulation occur. So it shows these are the cells that can respond to an increased spike in LH, luteinizing hormone. Secondary follicles we talked about become a vesicular follicle. That's when we see an antrum, right? We had antral cells. Now we actually see the antrum. This is that large cavity where all this fluid coalesces. And antral phase, the antrum, that area is really where we can get the nutrition so that if a oocyte is fertilized by sperm, it can live as it travels to the uterus to implant. So once our secondary follicle becomes our vesicular follicle, that's when the process is going to occur. I don't want to talk too much more about these other components. I don't think they'll ask you about them, or it's not worth your brain. So the cycle, again, this part is mainly just to make sure you have in your brain follicular phase versus luteal phase. That's the big piece where people get confused. So cycle is, we're going to talk about a 28-day cycle. Okay, obviously we know that can be very different and widely changed. We have two phases. Ovulation is our mid-cycle phase. So our follicular phase is day 1 through 14. So day of bleeding till ovulation, it's going to be vesicular follicular growth, or vesicular follicle growth. Then we have our luteal phase. This is where we have our corpus luteum activity. So days 14 through 28. Very limited amount of women have an actual 28-day cycle. It's really like 25 to 32 or even 21 to 32 is normal. Really, the luteal phase is almost always 14 days. I mean, it can shorten too, but typically what varies is your follicular phase. It's more common to vary, but both can clinically. So this is kind of a misnomer, this statement here. During our follicular phase, several different vesicular or antral tertiary follicles become sensitive to FSH and grow. From there, that's when they decide their one dominant follicle becomes especially sensitive to FSH. And then in the middle of our follicular phase, FSH levels are going to drop off. And that dominant follicle outcompetes other follicles. It's the only one to continue on to the next step. Other non-dominant follicles that started to respond to that FSH, they will go undergo atresia and apoptosis. In things like PCOS, polycystic ovarian syndrome, you can have some of those follicles not undergo atresia, and you can see some of them form cysts. You can see multiple follicles present in an ovary. You can see a multiple cyst formation, and some of those are from follicles that did not undergo atresia. That's how you get this strand of pearls appearance on ultrasound. But you have or haven't had repro? Haven't. Some of you maybe have, most of you haven't. So you'll see it. Strand of pearls, PCOS. You'll remember it forever. Undergo atresia and apoptose. And then sometimes in PCOS, those follicles will not adequately apoptose or undergo atresia. And then they can actually form cystic structures within the ovary. You can see that in PCOS. Those would be all tertiary follicles. You can also see cystic growth that's not follicle related though in PCOS. Yep. But you'll see this strand or string of pearls appearance on exam. It's all these follicles that are enlarged that have formed these cystic structures, but they aren't actually active tertiary follicles that could be ovulated at this point. In a different sense, if someone's undergoing IVF, you could have a lot of active, really large tertiary follicles, and multiple of those follicles can become selected because you're actually exogenously putting in hormones into your body. So you have more of a stimulated continual FSH, LH, progesterone, estrogen response. And that's how you can get multiple dominant follicles to then become released, and then they can become fertilized via sperm and then implant. That's why you can have multiple pregnancies that have multiple outcomes, either IVF or if you're taking exogenous hormones to try to increase your chance of fertilization. Twins, triplets, quadruplets, sextuplets, etc. Both from IVF, external, or even if you're just trying to increase via like an estrogen stimulant, there's different drugs you can take to induce ovulation, increase follicular size. Potentially. Probably wouldn't be as large of a response, but there could be, absolutely. I don't know if there's been studies done on it, but it'd be interesting to note. We do know things like Vitex, which can stimulate certain hormones, can help increase fertility, but it does that through Vitex chasteberry. It does that through more cyclical regulation and inducing ovulation, not necessarily due to follicle size and growth. Yeah. So it kind of would depend on the herb. Yeah. So ovulation, the one fun thing in here is Milchschmerz, which is a twinge of pain that you can feel during ovulation in some women. They've asked about that. What's patients experiencing Milchschmerz pain? Is it like pathologic or whatever? They've asked questions like trying to get you to think that it's a bad thing. It's not, just means there's pain that you feel during ovulation. So again, 1 to 2% of ovulations could release more than one secondary oocyte, which if fertilized could lead to twins. Identical twins though result from fertilization of one oocyte that then separates two daughter cells. That's how they're identical. One oocyte separates. So the luteal phase of the ovarian cycle after ovulation, the ruptured follicle itself collapses and the antrum itself will fill with clotted blood. This is referred to as corpus hemorrhagicum. Hemorrhagicum, thank you. They eventually just become reabsorbed by the body. The remaining cells and the internal fecal cells will enlarge to form a corpus luteum. The corpus luteum secretes progesterone and some estrogen locally. If no pregnancy occurs, the corpus luteum will degrade into corpus albicans, which is a spar, in about 10 days. And then you have this like luteolytic or ischemic phase that lasts 2 to 3 days of your luteal phase where your endometrium begins to erode. And that's what starts your menses or component of your menses. But if pregnancy occurs, the corpus luteum produces those hormones to sustain pregnancy. That's why it typically secretes more progesterone to estrogen. That's how you can measure progesterone levels throughout pregnancy. And then the placenta takes over that hormonal response at about 3 months. So I want to talk a little bit regulation, and then we'll take a break and move into our next section. So establishing this cycle, like cyclical patterns, is a big component of our female reproductive system. So before puberty, our ovaries are just going to secrete a little amount of estrogen, which inhibits our hypothalamic release of GnRH. That's before puberty. As puberty gets closer, if leptin levels are adequate, the hypothalamus itself becomes less estrogen sensitive. So GnRH is starting to get released. That stimulates then FSH and LH release by the pituitary, which then can act on the ovaries to start this process. This happens until a cyclical pattern is achieved, and then we have menarche, which is the first menstruation. So what are the hormones that interact during our ovarian cycle? GnRH stimulates FSH and LH. FSH and LH stimulate follicular growth and maturation and secrete sex hormones. The granulosa cells locally will release estrogen, and then LH and like kind of pokes on fecal cells to produce androgens, which the granulosa then can convert to estrogens. So remember, androgens, testosterone gets converted into estrogen in the peripheral tissue. We saw that picture before. If you forgot, here's your picture of it for your memory. So granulosa cells can also excrete inhibin, and they themselves are also going to convert testosterone to estrogen via enzymatic conversion. Yes. Absolutely. Oof, I don't know off the top of my head. We would have to go back to that picture of the HPA-HPO axis. But we could go back there. I don't have it in my brain. For testosterone to estrogen. Is that the enzyme you're asking about? Yeah, I don't have it in my brain. Maybe. Yeah. Yeah. Say, we can look it up. We can find it. Do I have all these things in my brain? No, definitely not. Thank you. Yes. They absolutely will ask about aromatase. Yeah. Then yes. Testosterone to estrogen. Yep. They love their enzymes. They do. They just love them. Just like they love their enzymes. They love their ligaments. It's just the thing. So our and aromatase, that's actually helpful. You can take an aromatase inhibitor, right? Which is going to decrease your estrogen production. So like there are clinical indications to know those things. Versus others, not so much. Negative feedback is going to inhibit your gonadotropin release. So in general, so increasing plasma estrogen levels, you're going to have that negative feedback occur, inhibiting FSH and LH, but also inhibin locally is going to do the same thing. It's going to inhibit our FSH release as well. Only one then dominant follicle that's already gotten large enough can withstand the dip in FSH that inhibin causes. And then that's how that one follicle typically is the one that dominates, and the other follicles then deteriorate. There is some positive feedback though in this cycle, which is important to note because it's different than typically in the body. We like negative feedback. There's not a lot of areas of positive feedback. Estrogen levels locally will rise as a result of continued release by dominant follicles. This is a positive feedback loop. When levels reach this kind of critical high value, there's a brief positive feedback loop that occurs in the brain and the anterior pituitary, which triggers LH surge. So that local follicle that got big enough that was able to withstand the FSH dip continues to produce estrogen locally. Once that estrogen level rises enough, the body detects it via chemoreceptors, because it's in the blood. Once that level reaches a critical high value, then LH released from the anterior pituitary in its big burst, stimulating ovulation. A role when what? Sorry. Critically high? Yes. Yes. Produced, do. Yeah, so you're gonna still have some estrogen present. Progesterone is by far the most common and elevated hormone of pregnancy, but your estrogen level will be increased as well because you're having increased secretion of both locally at the ovaries from that corpus luteum space. But progesterone is going to predominate because you want to prevent an LH surge. So estrogen is not going to ever reach that crit high level, but it's going to be present in general because you're continuously trying to build and grow baby, right? But you're never going to get to that crit high level because you don't want LH surge because you don't want to induce ovulation again. Keeps thickening the lining, but it's not going to allow for LH surges to occur. Yeah. Absolutely. It's going to thicken. So is progesterone. And then ideally, you get your stimulation of oxytocin and starts your uterine contractions at, somewhere around 9 months, ideally. Not always. Around 3 months, I believe is what I said. So around between first trimester and second trimester is when placental hormonal control. Correct. Yeah. And then placenta around that first to second try is when it's able, I think it is 12 weeks exactly, is when the placenta takes over hormonal control. Why they are lost? Yes. That's part of why they can be lost, because you don't have that localized hormonal control. You're relying on hormonal control that is less controlled, I guess. That's like the best way I can put it. They're more variable. Absolutely. Absolutely. There's also other stuff that happens in development in the fetus that happens the first 12 weeks, that if there's a crit error in development, right, in embryology development, that it's going to induce, a miscarriage because it's not viable for survival. Yep, absolutely. That's why a lot of times it's suggested that you hold off on talking about pregnancy to the world if you're not comfortable in that chance of miscarriage after the first or during the first try. Yeah. I say you do you. Okay. So we talked about LH surge, so I'm going to move on from that, but essentially that's the high estrogen level releases or triggers that LH to release, and a little FSH. The LH surge is going to trigger both ovulation and the formation of corpus luteum, which we talked about. And then shortly after ovulation, you'll see a decline in estrogen levels from where their massive spike was, right? Because we don't want to re-trigger another LH surge. LH is going to transform that ruptured follicle into the corpus luteum. It's then going to encourage it to secrete progesterone and some estrogen, like we mentioned, almost immediately. And it'll help maintain pregnancy. Negative feedback, though, inhibits that LH and FSH release because progesterone and estrogen is elevated. And then also you'll have some local inhibin that's decreasing that release as well. Then if no fertilization does occur, the corpus luteum will degenerate once LH falls. This will lead to a sharp decrease in estrogen and progesterone because we no longer have that corpus luteum. That'll end that blockage of FSH and LH. So then the cycle restarts because we end that negative feedback system. And if you wanted to have a little bit more phases of your uterine menstrual cycle, you have days 1 to 5, which is your menstrual phase. 6 through 14 is your proliferative or pre-ovulatory phase. And 15 through 28, which is your secretary or post-ovulatory phase. I'm going to move through the cycle really fast because I just want to give us time here. This, I think, is a helpful picture, just thinking about hormones, or you can think about structure, or you can look at them all together. So this would be my favorite slide. I'd say slide 94 is a good one to look at. 94 shows your LH spike and your FSH bump. It shows where your follicle is, follicle, ovulation, corpus luteum, and degeneration. Shows your estrogen spike and your progesterone spike. And it shows menstrual flow, a buildup of your endometrial glands and blood vessels, and then that kind of sloughing off. So if you are trying to high yield study for this cycle, I would say this slide 94, is probably your best bet because it gives you all the hormones, talks about the follicular ovarian phase, and compares it to the endometrial or the uterine phase. How are we doing? Do we want to keep pushing through to finish this, or should we break and come back to talk about estrogen and progesterone effects? It's been another hour, so it's up to y'all. Okay, no opinions. Awesome. what I'm gonna do, let's just get through estrogen, progesterone, and then we can take a break. And then we'll move on from repro into integument and blood. Okay, so we'll have a total shift in our world. So some pieces that we haven't already talked about with estrogen that I want to just mention. It's also going to induce our secondary sex characteristics, so growth of breast, increased deposit of subcutaneous fat, and then whitening and lightening of pelvis to prepare for birth. It also has metabolic effects. It's going to maintain low total blood cholesterol and elevated HDL protective cholesterol. That's why after menopause, postmenopausal states, once you have an estrogen decline, you can see dyslipidemias occur and increased risk in heart disease. It's also going to facilitate calcium uptake. That's how estrogen is going to relate to our bone structure and bone health. And then progesterone has a couple other functions. It's going to help promote changes in cervical mucus to allow for us to actually have sperm enter and sperm potentially penetrate our egg or oocyte. It's also going to inhibit uterine motility, so prevent contractions from occurring and prepare our breasts for lactation. And if you're a table type person, this is the summaries of estrogen, progesterone, and testosterone. So if you like looking at tables on the different functions of what happens, this would be a great place to go. I moved here. I did want to do a little aside on a few STDs, STIs. So chlamydia, asymptomatic commonly in females, more likely to be symptomatic, but can also be symptomatic in asymptomatic in males. Left untreated, sterility, infertility is a big risk. PID is also a big risk. You can see it in newborns getting it from the birth canal. So conjunctivitis, chlamydial conjunctivitis can be a infection you can see that leads to corneal scarring if untreated. Huh? Absolutely. That you did the other day. There you go. Chlamydial infection, and this could be a lot of your STDs that pass the birth canal in newborns, but specifically chlamydia is one that just really affects the corneal region and can lead to scarring and blindness. So it's just a good complication to put away. Trichomonas is a parasitic infection. Common question that people miss. We think about it as bacterial. We often don't screen for this. Unfortunately, you should. We don't, but it's easily treated. Gonorrhea, necessary gonorrhea. I just wanted to associate the bugs here for you. Again, most infections asymptomatic, especially in females. Symptomatic more likely in males with gonococcal urethritis. So male symptoms could be painful urination, pus. Females, you might get some symptoms of PID. Pelvic inflammatory disease, but may not, which is why screening is important. And then syphilis, our treponema pallidum. This one, if a fetus was infected in utero, they could be stillborn or die shortly after birth. So that's why we screen for these. The bacteria, if this one invades mucosa, which is why you can get these ulcerations, these chronic ulcerations in syphilis, which is called a chancre. And they're typically asymptomatic otherwise, but they can develop into secondary or tertiary syphilis. Secondary syphilis, you get a skin rash, fever, joint pain. It then can go latent. It may never progress to tertiary, but if it does progress to tertiary, that's typically when you see CNS involvement, nervous system involvement. And the treatment is penicillin injections, and if you've ever treated someone for syphilis, they are big ass injections, long needles, and slow. Penicillin is thick and goopy. It is painful to treat. I feel bad for every patient I've had to treat. They're just miserable, but better to treat it than not. So there you have it. All right, HPV, we talked about a little bit, so I'm going to move past that. HSV, genital herpes, herpes simplex virus. Most people don't know they're infected until you test it via blood. Can be passed on to fetus. You can decrease flares, but this is something that you're going to sustain and have for the rest of your life. You can't get rid of it, but you can decrease its spread. Yes. Ooh, for genital herpes, that's a good question. I don't know off the top of my head, but I wouldn't be surprised if there is. It could, yeah. I mean, that would be a good guess in that region. I would need to look it up to know. Sacral plexus. Yeah, absolutely. It feels good to me. I need to look it up again to know for sure. But it will stick around. You cannot cure it. It doesn't go away. All right. I think I'm to the point of where I wanted us to get to in the repro before we move on to HEMAT. I'm just going to look and see if there was anything else I cared about us covering for this. And then if not, we'll break and then move into integument. Sacral ganglia, sacral plexus. Yeah, I think, yeah, either would be appropriate. Totally. Totally. I think it's fair. All right. So again, just talking hormones, estrogen decline, atrophy of repro organs and breasts, even mood dysfunction, depression in some, hot flashes is your big one, gradual thinning of skin and bone loss. And then again, like I mentioned, because estrogen can help maintain adequate healthy levels of HDL and cholesterol, you can see the opposite occur, but we're not going to talk about HRT because this is not a treatment test. Okay, we made it. We made it through repro. Woo! All right, we're going to move into some hematology, a little bit of blood next. We'll take a break. We'll take a break for the next 6 minutes, come back at 10:25. We'll move into hematology briefly, talk about some cell lines, and then we'll finish up with integument, the skin, and we'll have done it. All right, online folks, thanks for hanging. We're going to come back in 6 minutes and move into 8C, which is hematology.